I will focus mainly on the recurrent abortion since the topic of miscarriage is so big. And nowadays also the role of progesterone and progestins is so hot in maternal fetal medicine. I will try to make some points maybe useful to understand where we are going with possible utilization of progestins, progesterone in this area. First of all, let me say that I'll try to outline the topic with some statistics and epidemiology to look mainly at etiology and the progesterone role and to make some counseling and management at the end. How we define a pregnancy loss? Abortus can be sporadic or recurrent, and we usually define as a recurrent pregnancy loss when it comes before 22 weeks of pregnancy and there are 3 consecutive losses. But this has changed in the last few years because woman age has increased in pregnancy, at the first pregnancy, especially in the Western world, and therefore many think that it's more appropriate to think about a recurrent miscarriage when there are 2 miscarriages in women which are over 35 or had problem of subfertility. And the incidence is around 0.3 to 1% of pregnancy is going to increase, at least looking at the recent statistics. Unfortunately, most of the published studies on management contain important confounding variables which either weaken or totally invalidate their conclusion. And among the effects are inconsistent definition, which are very common, different investigative protocol, which are very universal in many studies, lack of normal controls because are difficult to achieve, just to think what you compare with a recurrent miscarriage, and time over which the study population gathered because, of course, the incidence of 0.5 to 1% is not a big incidence. But there is another problem, is a considerable psychological pressure to find the cause and to do something in this patient because couples are very stressed and they stress at their time the obstetrician. And it is also to note that when we are looking at comparison in the area of human beings, this is a very always heterogeneous area, even when all patients begin with the same clinical diagnosis. But unfortunately, one is different from the other. The spectrum of pregnancy loss goes from the so-called preclinical loss to the clinical loss. The preclinical are the fact that fertilized ovum doesn't divide, blastocyst doesn't plant, blastocyst lost with a menstruation and so on. While the clinical loss, which are more evident because at least we have a test which proving the pregnancy started, is dividing embryonic, fetal, and late miscarriage, let's say, loss before 20 weeks gestational age, according to some definition, and stillbirth when is later. If we look at the frequency, you will see that pre-implantation is the majority. So if I look at any statistic around the world, 50% of pregnancies start, but they never reach a stage which are knowledgeable. So the preclinical and the clinical, you see, are a minority at the end, 30%. And, the later stage is even a smaller percentage. If I look at likelihood or repeated pregnancy loss, I will have to distinguish between patients who have a prior live-born and those who have no prior live-borns. And you see that the risk increase according, in any case, to the number of abortion and goes up to numbers which are, let's say, similar at the stage of 4 consecutive abortion after a prior live-born, when I have a patient with a 3 prior live-born, which is even a 60% recurrency rate. And this is, frankly, maternal age dependent. Now, the statistics tell us that 50% of all pregnancy end in a spontaneous abortion and that they are unnoticed. 30% are lost between implantation and the 6th week, and 65% of first trimester losses are due to chromosomal abnormalities. And the rate of loss increases with age. One of the factors that sometimes guarantee, at least to the obstetrician and sometimes to the couple, that everything is going right, is to look at embryo or fetal heart tone. And observe, let's say, as early as 6 weeks on ultrasound. Okay, if is the first pregnancy or there are no loss before, the possibility that pregnancy will end in a loss within the first 2 trimesters is less than 5%. But if we have a patient with a repeated pregnancy loss, even though I will see an embryo heartbeat, then there is a 4 to 5 times greater chance that in any case that pregnancy will end as an abortion. What are the epidemiological data which connect the repeated pregnancy loss with any, let's say, factor? Maternal age, as I said at the beginning, smoking has been linked, alcohol, some abuse of the substances like caffeine, the environmental factor like anesthetic gases or some dry cleaning substances, but there are not many which have been done, also because of difficulties to find this kind of patient and to have a homogeneous population. Therefore, even we do an extensive workup, we will fail to find a recognizable cause in up to 40% of cases. And you know that if we do go in any textbook or any paper that is dealing with a recurrent pregnancy loss historically, we found a series of factors which are comprising genetic, anatomic, endocrine, infectious, immunologic, and some miscellaneous, as I said. What are their, let's say, incidence within this pathology? Genetic probably, as a recurrent miscarriage, is not so important as endocrine and particularly immunological, which are probably the most important. But you see that we have an area of an explanation which is still troublesome. And looking to the number of abortion, this is a study we accomplished a few years ago, we have observed that more abortion we have, more we are able to identify immunological pathology within this woman, or let's say immunological vascular pathology, which is most appropriate. I want now to deal with a few factors to make some rapid statement about what we know. Anatomical causes are probably not associated with early first trimester losses, while more plausible explanation for late or second trimester losses. And surgical correction is not always recommended nowadays following early first trimester losses. And this is something that many people agree nowadays. According to infectious causes, we must say that there is no true association between any bacterial viral organism and repeated pregnancy loss. Although only endometrial ureaplasma, which is very difficult to demonstrate, has been associated with recurrent pregnancy loss. And chlamydia antibodies have been found more frequently in women with recurrent miscarriage, but chlamydia has been not identified clearly in this patient. So it's a rare explanation for recurrent miscarriage to have an infection cause. Thrombophilia is a very hot topic in the last decades. Many are the congenital thrombophilias. All of them are implicated mainly in excess rates of thrombosis in the non-pregnant state. This is a real risk. But you know that in the last few years, they have been associated with several perinatal worst outcome. And particularly, a study has shown that anticardiolipin antibodies, lupus anticoagulant, prothrombin heterozygosity or factor V laden and so on, have an increased role in the determination of early pregnancy loss. If we look to some of the data that bring, for instance, factor V laden with a recurrent pregnancy loss less than 13 weeks, this apparently is a factor which is involved. But other has not been so well related. So factor V laden mutation has been related, activated protein C, prothrombin G, 2021OA mutation, but for instance, the methyl tetrahydrofolate mutation or deficiency of protein C and S have not been clearly linked to recurrent pregnancy loss. Of all the thrombophilias, the acquired one, the antiphospholipid syndrome, is probably the only one and possibly the one of etiologies which single etiology which has the major impact on recurrent pregnancy loss, being responsible up to 15% of all the cases. You may presume to have an antiphospholipid syndrome based on clinical findings, but you know the major problem is to find an agreement on laboratory finding to repeat lupus anticoagulant antibodies, anticardiolipin antibodies, either IgM and IgG, at least 2 times at 2 months apart, and there is rules which have been published recently on the exact definition. However, if we are in the presence of an antiphospholipid syndrome, then we are pretty sure that may be the cause of a recurrent pregnancy loss, and we have to take some steps in the management. Endocrine factors, there are more myths than realities. There are a lot of common misconceptions about endocrine factors. I think that thyroid dysfunction and uncontrolled diabetes are for sure linked with recurrent pregnancy loss. Therefore, I think that screening with TSH, prolactin, and diabetes is recommended. Endometriosis is not, at least as far as a consistent study, have been associated with increased pregnancy loss, and also the polycystic ovary syndrome does not increase the risk of abortion unless it's related to the presence of diabetes. Now, as I said, and just Selim has pathway very well for my subsequent part of the talk, the key problem is implantation. He talked about the progesterone role, but we know that 75% of abortion, particularly recurrent abortion, are due to failure of implantation. So it comes to the role of progesterone. And I think that before getting in details about which can be the real role of progesterone, at least as we know nowadays, because studies are going on and new data are coming on this multifaceted hormone, a little bit of history. You know that this hormone is very old. More than 85 years now. It has been discovered by an anatomy professor at Rochester Medical School, and the name has been given during a dinner in London with some other eminent endocrinologists, and they call it progesterone, derived from progestational steroidal ketone. Progesterone is of paramount importance in most parts of the process of reproduction. It is indispensable for pregnancy maintenance, but regulates menstrual cycle implantation. And the multiple physiological role has been extensively studied since 1935, when it has been synthesized and later became available in the market. However, the use in the pathophysiology of pregnancy remains arguable for various reasons. First, there are very few randomized controlled trials. Have you seen? Salim goes back to an 82 study to show something about, but nothing else after, for instance, 1982. Secondly, another important issue is concerned the route in which the hormone is administered. Because the first route was intramuscular, and it was so expensive that a vial at that time, like the 40s, cost like the machina nowadays, but at that time was difficult to synthesize, and the machina is another problem. And the second, when it comes to the oral route, it was shown not to work at all for several reasons we'll explain in a moment. So, which are the possible ways of administration? Administration has been attempted everywhere, since intrauterine, rectal, suppository, sublingual, intranasal, transdermal. But for transdermal to be, absorbed by the skin, we have to cover half of our body with progesterone in order to have the same amount you can get from the vaginal route or the oral route. Then the most popular are all intramuscular and transvaginal. The real problem is that whenever you give progesterone by mouth, it is catabolized rapidly by the liver and nothing remains, or even there are sub-metabolites of progesterone which interact against the action of progesterone. And only with the microionization you can observe at least some advantages, because microionization brings very small particles which enhance the aqueous dissolution and intestinal absorption. Progesterone, which is nowadays available, is an extract of a chemical extracted from a plant, the Dioscorea, which has been found by Russell Marker in 1940. He was able to buy some lands in Mexico and to produce progesterone as much as $1,000 at that time per gram, and he was killed for that. There's a very bad story around Russell Marker. And however, in any case, the hemisynthesis of progesterone is coming from that particular wild yam plant, and nowadays still is the producer of progesterone. The advantages of having injection is that, of course, you may reach physiological plasma level. However, it's very painful, as local infection abscess, occasional allergy, need someone to make this injection, and there have been some description of acute eosinophilic pneumonia induced by progesterone injection, for instance, used in RT treatment. There is another way we can give progesterone by vaginal route, and look at the penetration with vaginal progesterone. You can use different ways, either vaginal anal suppositories or vaginal jelly or micronized formulation. And of course, the synthetic progestins came because of the unavailability of an oral good, reliable route of natural progesterone. And the first were developed for contraceptive use, and many of these compounds have different receptors binding, as we see, with different side effects according to progesterone, according to the different progestin which have been developed. We know that the pharmacodynamics of progesterone implies a receptor binding, an anti-androgenic effect, an anti-mineralocorticoid effect, some tranquilizing effect due to the metabolites, and hypnotic effect even, but the major effects are on endometrium and may have an action on female breast. If we look at biological activity, looking at natural progesterone versus synthetic progestin, you see that drospirenone, but particularly dihydrogesterone, have very similar activity on receptors, this is very important, and much less antiandrogenic or effect on GABA, which exclude any neurological activity of dihydrogesterone. Because if you give orally progesterone, you have some hypnotic effect in the woman. Dihydrogesterone has no suppression of pituitary glands, can be given after ovulation, and usually the suggestion is to give at least for 3 months, and estrogen or ACG can be used at the same time, and the only thing is that some reports have showed a relatively late development of endometrium after using dihydrogesterone in artificial cycle. However, this has been challenged with some data we'll show now. But the major difference is between injectable natural progesterone and 17-hydroxyprogesterone caprate, which is being popularly used recently, especially in the maternal fetal medicine. This is a in vitro experiment, recalling the experiment from the studies in 1960, in which progesterone was given after inducing contraction in strips of myometrium activated by oxytocin. You can see in the first 3, there is a, I wrote to back, yes, this one. In the first 3, we have oxytocin-induced contraction, and then progesterone given and inhibition of contraction. If I give a 17-hydroxyprogesterone caprate, I have no inhibition at all of contraction. And this is a major difference, for instance, in the myometrial activity of progesterone. So, in conclusion, looking at different possibility of administrating progesterone, we have an oral route, taking into consideration that for natural progesterone, we have an hepatic passage and metabolites which possess hypnotic effect, while dihydrogesterone is fully affected by oral route. Then we have an intramuscular route with discomfort, granulomas, and of course we may choose for daily and depot. This is good for sometimes compliance, but there is a limitation on intramuscular route. And the vaginal, which avoid the hepatic passage and give the first uterine passage, although we don't know very well how much are the concentration reached in the blood after at least a few hours. Okay, now what about progesterone and pregnancy maintenance? We should pay attention to the first work done by Georgiana Seager-Jones, which was the first to give a serious look at the endometrial receptivity by describing luteal phase defect or dysfunction correctable with progesterone. But it was really Arpad Chapo, which was an Hungarian investigator who lives in Canada, who succeeded first in isolating actin myosin in the myometrial muscle. Then he developed a theory that hormone progesterone blocks the contraction of muscle in pregnant uterus, and his work was also linked with an anecdotal story that Salim told you before, the lutectomy in some patient and providing progesterone to support pregnancy, and he was the one who did that particular study. Chapo argued that if progesterone is indispensable for normal pregnancy maintenance, then progesterone withdrawal has to be a prerequisite of pregnancy termination. And this has opened a wide series of investigation looking at the role of progesterone, particularly in implantation at the beginning of pregnancy. And nowadays, we are keen to believe that the major role of progesterone is in titrating the immunotolerance system of the mother in order to accept the pregnancy going on. What is happening, in fact, at the beginning of pregnancy? We have two systems which work in our body, Th1 cytokines, Th2 driven cytokines, and you can see how many are the name and the cytokines. And there is a balance between these two normally, but if we go toward the Th2, then we have major anti-inflammatory reaction, which is good for pregnancy, while if we go and maintain the Th1 drive, we go mainly to have pro-inflammatory reaction, which brings against pregnancy and going to miscarriage. The major substance which is produced by the activation of progesterone receptors in the leukocyte is a progesterone-induced blocking factor called PIBF. This factor has the possibility to block the synthesis of prostaglandin and to convert cytokine balance toward a Th2 system, inhibiting directly also not only some cytokines but also the natural killer cell activity present in the uterus. Now, if we look at what is happening in the interaction between the hormone produced by trophoblast and the increasing progesterone concentration produced by the corpus luteus, we will have two major areas of action of progesterone. One is regulating prostaglandin production and angiogenesis through VEGF receptors. The other is facilitation of immunotolerance by decreasing or altering some of the reaction we have usually in our body, which maintain the balance between the Th1 and Th2 system. So progesterone at the end induced the production, increasing progesterone induced production of PIBF, and PIBF induce a Th2 driven system which normal progress pregnancy. If we have enough PIBF production, then we have asymmetric antibodies and we control the natural killer cell and we protect the fetus. On the other hand, if the level of these factors are low, then we have symmetric antibodies Th1 and we have a cytotoxic inflammatory reaction and we go toward abortion. I think that the study which proved that not only progesterone but particularly dihydrogesterone has a role on this are striking. This study, which has been published by the same group who has proposed PIBF as one of the key substances to regulate immunotolerance in pregnancy. And you can see that according to the dihydrogesterone concentration, we have an increased PIBF concentration. But what is more important is that dihydrogesterone turn over the cytokine Th1 production, decreasing it more than who does the micronized progesterone, and increasing the Th2 cytokine levels. So it looks that dihydrogesterone has a key role in this switch between a normal immune system to a, let's say, normal immune tolerating system that we need in pregnancy. So dihydrogesterone induced by IBF upregulate Th2 cytokines and decrease natural killer cells, and directly upregulate Th2 cytokines and downregulate Th2 cytokines. So the progesterone modulates the mother-to-be immune response from rejection to protection. And you know that going on, progesterone has also, as I show you, a activity on the myometrium promoting quiescence, while when there is a decrease of progesterone receptor activity toward the end of pregnancy, then we have the possibility of activating the myometrial action and then to start a labor. So in synthesis, the progesterone activities which are crucial in pregnancy are the promotion of decidualization, the, let's say, favorable induction of trophoblast invasion up to a certain point, and of course, the action on uterine contractility. Now, what is the link between progesterone and recurrent miscarriage? There is an evidence of progesterone efficacy because, as also Salmi said, the removal of corpus luteum during pregnancy brings to abortion, and if we use anti-progesterone drugs, we can have a pregnancy termination. But in luteal phase insufficiency has been demonstrated, as assisted reproductive technologies, progesterone has been shown to be crucial in maintaining pregnancy for the success. But if we look at meta-analysis of trials, looking at the role of progesterone or progestins in recurrent miscarriage, we can find only studies going back from 53 and only one very recent 2005. Only 4 studies randomized control trial with different type of intervention and different, you say, amount of progesterone. And this is very unfortunate. However, the meta-analysis show there is a favorable effect of progestins toward, decreasing the rate of abortion in patients which has recurrent pregnancy loss. So there is a favor of progesterone in this. And also, the last Cochrane database systematic review says that there is a statistically significant decrease in miscarriage rate compared to placebo or no treatment when we use progestogen in miscarriage, in recurrent miscarriage. The Cochrane previous studies, which are very old, added to Zibde, which is coming from Jordan, on P4, and this is a comment from Salim Daya. He published a study on this on Maturitas, say that for every 5 women given progestin treatment is 1 extra successful outcome versus no treatment. So I think that the number needed to treat is very good, at least according to this data. I show you briefly 2 studies that we have performed. These are 47 cases of patients with more than 3 abortions and a lot of autoimmunity in different kind of autoimmune markers. And we gave progesterone in this case, 2-to-1 case control. You can see that we reach only 3rd pregnancy, or pregnancy only in the cases which have been treated with progesterone instead of no progesterone at all. And more recently, we use progesterone with aspirin in autoimmune negative and autoimmune positive. And you can see that only if we add progesterone, in autoimmune positive patient, we have the same rate as in non-autoimmunity negative patient that we are giving only just aspirin in this trial we just finished. So there are still light and shadows. However, we may do a summary about what we know about recurrent pregnancy loss. If we diagnose, as I said, an antiphospholipid syndrome, which is something that we have to look, in any case we have a couple with recurrent pregnancy loss, then I think that the treatment of choice is to give aspirin with a low molecular weight heparin. Don't think that leukocyte immunization or intravenous immunoglobulin still have a place in this treatment. However, for the other thrombophilias, it's still very debatable to associate aspirin and low molecular weight heparin because it doesn't seem to have the same effect. Natural micronized progesterone has a role in prevention of recurrent pregnancy loss, and the dosage is suggested from 200 to 400 milligrams intravaginal or even 600 milligrams a day. And it can be continued because you know that at least for natural progesterone, there is also the possibility to prevent preterm birth. For dihydrogesterone, there is still a role in the prevention of recurrent pregnancy loss way of administration has much higher compliance because it's oral route, and suggested dosage is between 20 to 30 milligram a day. From conception or positive test, we continue until 20 weeks. In the RT cycle, the majority of authors propose 30 milligram a day. Now, there is a strategy in many studies nowadays to associate modulator of immune deficiency, like corticosteroids, aspirin, and heparin, along with the progesterone, in case in which we don't establish a real etiologies of recurrent abortion. However, I must say that these rely on, let's say, still experimental management, however, is coming to be much more popular than in the past years. The couples with the recurrent pregnancy loss require understanding, sympathetic, supportive doctor. Multiple visits, mainly during the first trimester, but we should know that without doing anything, but just with psychological support, according to the history of the patient, 30 to 50% of them can succeed to have a successful pregnancy without anything. However, as I say, there is a pressure to do something. Patients who come out from the office of a doctor without anything prescription, they think that the doctor is not good at all, or doesn't understand what he is doing. I think this sentence is very nice. I reply from Clark, a paper he published in 1999. Why did your mother reject you? While peering down a microscope tube with the remnants of a spontaneously aborted embryo. I think that recurrent pregnancy loss is emotionally frustrating for couple experiencing loss, and often is a frustrating challenge also for ourselves. This frustration often results in recommendation of unsubstantiated tests and therapies of dubious efficacy. And I think that concluding, we don't have still a very good consensus therapeutic regimens, but we know that in antiphospholipid syndrome we should combine aspirin and local molecular weight. In thrombophilic patients there are still options open, but the role of progestins is increasingly accepted because especially with the dihydrogesterone, which are no very good safety profile, I think that patients are happy to take some drugs that they know they may help, in overfacing this problem. The role of steroids is still controversial, and is under investigation the role of antioxidant and polyunsaturated fatty acids, at least in some etiologies of abortion. And I think that with this, I thank you very much for your attention.
Thank you.